Meredith, I feel like we had to cut our cardiac playlist a little short last week. So I think we need to add Heartbreaker by Mariah Carey and Jay-Z.
What about Heartbreaker by Pat Benatar?
Ooh, okay. I'll one up you. Heart of Glass by Blondie.
Classic. And for those emo kids out there, My Paper Heart by All American Rejects.
You would. And for those pop junkies out there, Heart Attack by Demi Lovato.
Also on theme for the episode. So with that, you can check out the playlist we'll post somewhere for some other Easter eggs.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like Moral Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we are responsible if you screw up. You should always do your own homework and let us know when we're wrong.
And welcome back to the Curbsiders. I'm Moni Amin, joined by my co-host, Meredith Trubitt. And tonight we have our part 2 of our conversation with Dr. Sanjeev Francis about ACS. Meredith, will you please remind the good people in the audience what it is we do on this show?
Sure, Moni. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge.
And if you missed the tail end of part 1 last week, here's a preview of what to expect tonight. We talk about the warranty on coronary CTs or stress tests, as well as the specifics on management. And lastly, who needs to be worked up for that post-sepsis troponin?
And if you haven't already listened to part 1, highly recommend. It was a good part 1.
So we will move on to our next case, Mrs. Smita. She is 67. She has a history of hypertension, diabetes, and hyperlipidemia. She comes to the emergency department with sudden onset substernal chest pressure that started while she was walking her dog. She reports she has never had pain like this before, and she follows regularly with her primary care provider. And due to her risk factors, she had an outpatient cardiac CT a year ago that was normal. She's now on insulin for diabetes. She's on losartan, amlodipine for hypertension, and rosuvastatin for cholesterol. And her initial EKG and troponin in the emergency department are normal. She has had a test in the last year, coronary CT. So does that mean that she doesn't need further testing? Because I think the part that's always hard for me is are these cutoffs kind of arbitrary, or is that's the part I've always been confused about? Because it feels like if there's even a little plaque, it could kind of rupture at any moment, right? So I've always kind of wondered, are those cutoffs hard and fast, or yeah.
No, it's a great question, and it sort of gets to when you have a normal test for coronary disease, whatever your imaging modality is, whether it's coronary CT or it's a nuclear test, and if it's stone cold normal, so it really has to be completely normal. So for coronary CT, it means that your calcium score is 0. And you didn't see any non-calcified plaque. It's pristine in order for it to be normal, because any incremental amount of coronary disease actually increases your risk. So a little bit of calcium, non-calcified plaque, then that starts to incrementally, add to your risk. So let's say it was completely normal and you believe it, good quality study. But your question's a good one, is that CT isn't 100% accurate because it has a limited resolution. So you may be missing smaller amounts of atherosclerosis, and that particularly becomes challenging when you have patients who may not have pristine textbook quality images. There can be artifacts, there can be attenuation artifacts based on someone's body habitus. A higher BMI decreases our ability to detect plaque. There can be arrhythmia effects, if someone has atrial fibrillation or if their heart rate's too fast. So all to say, from a coronary CT standpoint, a negative or normal coronary CT is actually probably a spectrum of things depending on that. But let's say you have a high quality study and it's stone cold normal, clean coronaries, whistle clean coronaries. What's the warranty period for that? So how confident can you be, that you're good? You don't have to worry about an acute coronary syndrome. You could actually just leave the emergency department. I don't need to do any testing. You had a clean coronary CT. Within a year. So it's a great question because it depends on what series you look at. So from a population standpoint, if you have a totally normal coronary CT, then your event rate is typically very low. And that can be very low from 7 years up to 10 years. And that's defined as equivalent to your age-matched population that does not have, coronary disease. But that's not zero. So if you look at the chest pain ED population, it's a slightly different warranty period. So for coronary CT, it's about 2 years is what the current guidelines suggest, that your event rate is low enough where you really have to think hard about whether you want to repeat some testing. Doesn't mean that you're not going to repeat testing, but your likelihood that you're going to have an event within that 2 years is low. Again, that's for a truly stone cold normal coronary CT. For any of the other stress testing modalities that we talked about, stress echo, nuclear stress test, it's only, the warranty period is about a year. So that, again, doesn't give you a lot of durability. And part of that just reflects the fact that things change. You mentioned that you can have a plaque that's not causing any reduction in blood flow that can become unstable. And you've got a clinical milieu of risk factors and inflammation. And that is an unpredictable event. So even if you had a truly normal coronary CT, you can still have someone that presents with an acute coronary syndrome, within that warranty period. But that gives you some sort of rough sense of, of how statistically that person's likely to behave. But the risk is never zero.
Okay. In her case, with her normal EKG and troponin, is there anything you're looking for that would make you more suspicious and like, oh, maybe we need to watch her? And we kind of went into this earlier about kind of the delta trope and like how would we employ that in her or not?
Yes, I think if you have the sort of 5th generation high sensitivity troponin, then you're not going to just rely on that initial troponin. You're going to check serial troponins, and that could be, a 1 hour and 3 hour time point, or it could be a 2 hour and sometimes 4 hour time point, depending on the clinical circumstance. There have been studies that have suggested that if those first 2 troponins are normal, meaning don't get you into the myocardial injury or are not in the indeterminate phase, are truly normal, that from a population standpoint, your event rate is low. And event rates usually are defined as, 30-day risk of having a major adverse cardiac event. And that's usually sort of a spectrum of ischemic syndromes, but it's not zero. So I think that's where you sort of get back to this. So for this particular patient, you're describing, age, you're describing multiple risk factors, and you're describing a chest discomfort syndrome that actually feels like, cardiac, or at least possibly cardiac, chest pain. In my opinion, you would be obligated to at least get a serial troponin, and I'd probably do the full 013 or 024, depending on your institution.
Great. That's what happens. So her second EKG is normal, but her repeated high sensitivity troponins are elevated. So she's getting admitted. This comes up a lot on like our hospital medicine episodes, where obviously like diagnostics management are kind of going on simultaneously. But for the sake of this, let's kind of start with the diagnostics. So for her, once you see that troponin elevation, what like kind of are going to be your next steps besides us calling cardiology?
Yeah, so now I think you're building your case that she has an acute coronary syndrome, and you're labeling this in non-ST elevation MI, assuming she doesn't have ST elevations on her. Now you're getting serial EKGs because that's the right thing to do. But let's say she's still in that non-ST elevation MI bucket. Now you're trying to determine what's her risk within the ACS bucket. So there's additional risk stratification that happens once you've made a diagnosis of an acute coronary syndrome. So now you're using sort of a different, risk score and different metrics. And the one that I'd say that we commonly use that has a pretty robust evidence base is the GRACE risk score. And the GRACE risk score includes a number of clinical factors, including evidence of heart failure and vital signs. And you plug this in, and if you get a number that's elevated, it suggests that that person is at higher risk for a major adverse cardiac event sooner in their hospitalization. And based on the recommendations, you might advocate for a coronary angiogram early. So early would be sort of within 24 hours. If it's someone who's really high risk, and what would high risk be? They're still having active chest pain. Their EKG is showing worsening ST depressions, or they're having really, worrisome dynamic changes. Like maybe they have chest pain, they have deep ST depressions, then you give them nitro and it resolves, and they have recurrent chest pain. That tells you that cadence of recurrent chest pain with ischemic changes puts someone in a higher risk category. If they have heart failure, if they're having ventricular arrhythmias, you might make the case that they should go immediately to the cath lab. So there's this sort of immediate for the really high risk where they're hemodynamically unstable, unremitting chest pain. That person, you may have a strong case to say they should go right to the cath lab. But let's say they're not in that really high risk category. Then you can use, risk scores like the GRACE risk score to identify should you advocate for early, which is typically the goal is within 24 hours for that patient.
So the goal is within 24 hours. If they stay in kind of that, there's no of those super high risk characteristics that you're seeing, and they come in on a Saturday morning, do they wait till Monday? Or like, what should I be doing in the meantime to say, like, hey, this actually needs to go sooner or not? I feel like every one of these comes in on a Saturday morning.
Yeah.
Yes.
If you're at a community hospital, right, are you having to get on the transfer center and move them, or,
Yeah.
Yeah, it's a great question because you may have patients that have that GRACE risk score that puts them in the higher risk category, where by the guidelines you would recommend, early coronary angiography, but that's not always practical. It's not practical if you don't have, a cath lab in the hospital that you're working at. And even if you do have a cath lab, there's real staffing, issues that may prevent you from taking that person. So, in that interim phase where you've identified that they have an acute coronary syndrome, then it's really you're starting them on a number of different medical interventions with the hope of stabilizing their ischemic syndrome, so that way they can get their angiogram, at the time, the soonest that they can. If you have someone that is, and you don't have, a cath lab on site, but their risk score is higher, you might advocate for earlier transfer, because one of the things that may happen is that just because they're stable now, while they're waiting, 12 hours may go by, they may start to develop high risk features. So I think that initial, risk assessment should also help you triage someone. And even if they get transferred to the hospital that has the cath lab, doesn't mean that they're going to go straight to the cath lab, but at least if something were to evolve, they're in a place where you can activate the cath lab more, more urgently. So I think part of it depends on, where you're working and what your access to a cath lab is. But it's a great question because practically speaking, there are a lot of patients that will have a risk score where if everything was, at your disposal, you might, cath all of those patients within 24 hours. But the system and the resources may not always allow that. So then I think you're looking for your approach to medically managing that patient while they wait for their, angiogram, and being attuned to things that should change your assessment of can this wait. So in addition to the clinical things that, that I had mentioned, while that patient is sitting on your service, even if they're not having symptoms, I might get an EKG that next morning. Even if I did my serial EKGs when they came in, I reassured myself that nothing had changed, I'll get another EKG in the morning. Sometimes I'll even check another troponin the following day. Like I've gone through that cycle. It was positive, but it sort of peaked and then sort of started to come down. If you're trying to build confidence that you're not, seeing worsening myocardial injury as a result of an ischemic syndrome that you don't quite fully have managed medically, those could be things that could either reassure you or point you towards I need to involve, a cardiologist or transfer the patient if it's not available at your site.
And like for the person at the community hospital, thrombolytics only indicated if you're seeing ST elevations, or even it like you're not going to use thrombolytics just because there might be this waiting period.
That's absolutely right. So thrombolytics are only indicated for ST elevation MIs. There's no role for non-ST elevation MIs or unstable angina. That's actually been tested in the past. Those trials really didn't show any benefits. So thrombolytics only if you have an ST elevation MI.
Okay. So I think then that segues us into like what her medical management should be. So let's start with aspirin. We're going to go through I think each one and talk a little bit about dosing and everything. So for her, aspirin, she obviously needs, these patients typically in the ER will get a loading dose. Is that absolutely necessary, and that's part one. And then they can stay on the aspirin through whatever intervention.
Yeah, so number one, they should all get a loading dose of aspirin. And if you're not sure, if your patient tells you, I took aspirin at home, or you can't get the EMS records to see whether an aspirin was given, give a full loading dose of aspirin. So that's 325 milligrams of aspirin. A lot of health systems have moved away from the enteric-coated aspirin, and there's some evidence that the chewable aspirin might be absorbed, quicker. But really, you're using the full sort of 325 milligrams as a loading dose, and that's your one-time dose. And then the next day, then you're starting your maintenance dose of aspirin, which is typically 81 milligrams. Historically referred to as baby aspirin. So it's a loading dose of 325. And if you can't confirm that they got that en route or got that at home, then just give them another 325, and then you start the maintenance dose the next day.
Okay. And then she has, I believe, the hyperlipidemia, so may already be on a statin, but if they're coming in, it's automatic, like high intensity statin. And if they're already on high intensity, I guess you're going to check a lipid panel and then decide what other like cholesterol management she would need as like risk reduction.
Yeah, so it's a great question. So, in the setting of an acute coronary syndrome, your LDL levels are going to be a little bit lower than they might be sort of when you're out in the wild before you have an acute coronary syndrome. And some of that is just due to LDL receptor, cycling and LDL clearance. So, I never make a decision about statin dosing on that acute LDL, meaning if it looks okay, I'm not going to back off on the statin. And if it's an acute coronary syndrome, the key thing is a high intensity statin, and you've got two statins to choose from and sort of two doses. So you have a torvastatin, and it's really 40 milligrams or 80 milligrams, or rosuvastatin, 20 milligrams and 40 milligrams. So those are your only options, for high intensity statin. And if it's someone that's coming in with an acute coronary syndrome, I say go big. Go with a Torva 80 or Rasuva 40. And then if someone has a dramatic response as an outpatient and their LDL is 20, then I might back off on it and say that, okay, we can come off of that, or if they have side effects, obviously. But in that initial presentation, I would always, go with the highest of the high intensity statin. Still check a lipid panel because it gives you some useful information, but the LDL that you measure acutely may not be reflective of what their LDL is going to be when they're not in this sort of acute phase scenario.
Okay.
As far as alternative agents, that's a great question. So now, our LDL threshold for patients with acute coronary syndrome has certainly gone lower and lower. I typically won't add a second agent during that index hospitalization unless I'm concerned that they have familial hyperlipidemia, or I've got a lot of evidence as an outpatient that they never got their LDL, to the target, which typically is going to be an LDL less than 70 for someone who has coronary disease, less than 55 in some of the guidelines. So that may be where if they had not achieved that before and they're coming in with an event, I might think about, additional medications. So either, ezetimibe or a PCSK9 inhibitor would probably be the two that we would think about first.
Okay. I feel like that was the easy part. So now going to P2Y12 inhibitors, obviously, I think we have like the three to consider. Can you just kind of go through like in which patients are you thinking about which one? And then I'm also very confused at this point in time whether as a hospitalist we should be loading them or do we just wait until cardiology says one way or the other?
It's an excellent question. And this has sort of evolved even from my training. So way back when I was a fellow, which I'm now dating myself, there was always this nervousness of should I start, and at that time it was a 2B3A inhibitor. Should I start, P2Y12 inhibitor before the catheterization? And there was some evidence early on that upfront platelet inhibition may improve short-term outcomes. But fast forward to sort of our current era, right now, if you abide by the guidelines where you're generally going to get patients into the cath lab within that sort of 24, 36, 48-hour period, there's probably not a lot of benefit to starting your P2Y12 inhibitor ahead of time. So there's three to choose from. So we've got clopidogrel, we've got ticagrelor, and we've got prasugrel. So those are the three that you're typically going to see patients on. And I would say right now, like if you're in a hospital that has a cath lab, has a cardiology consultant service, I would definitely run it by the cardiologist. There's a lot of variation in how this is practiced, but the guidelines have moved away from mandating that every patient who comes in with an acute coronary syndrome gets an upfront P2Y12 inhibitor before their coronary anatomy is defined. And part of that has to do with, shifting in the timing that these patients will go to the cath lab. So it used to be that these patients might wait days, not just 24 hours, but it could be days and days, in which case, you might see some patients that will get loaded and then get transferred. And in that particular patient, and we're in a health system where we do have those patients where it might be 3 to 4 days, depending on bed availability, depending on transport, where you could make an argument that they should be loaded, with a P2Y12 inhibitor. So the only one that I would choose up front without knowing their coronary anatomy is clopidogrel, which is sort of the first one that we that we commonly use. And again, there's some nuance to that. The trials that have looked at upfront P2Y12 inhibition with ticagrelor or prasugrel really have not shown a compelling benefit. And again, if you're within that reasonable range of going to the cath lab, I'd say most are now avoiding that upfront P2Y12 inhibitor. So it's aspirin, heparin, which we haven't mentioned. That's going to be your antiplatelet and your antithrombotic regimen. So we sort of moved away from that, but that used to be a big question of, should I just start them on that? So what's the downside of starting someone on clopidogrel? It's not so much bleeding during the procedure, although that might be a little bit increased. It's the recognition that there is a decent chunk of those patients that's going to have multivessel coronary disease, that's going to need bypass surgery. And then you're going to usually have to wait several days for the P2Y12 inhibitor to wash out, because we know that bleeding risks, during open heart surgery are increased if you are on a P2Y12 inhibitor. And certainly in our health system, we just have a lot of multivessel coronary disease. So that can sometimes delay the flow of patients. It's not against the guidelines if you have done that, but the guidelines have really moved away from pushing that upfront P2Y12 inhibitor. So in some ways, it's become a little bit easier.
Okay. Speaking of bleeding risk, anticoagulation, heparin versus low molecular weight heparin, kind of the dosing and how long. And then I have another question after that, but start there.
Yeah, so in general, I would say for the patients that will make it to my service, they're coming ostensibly for a procedure. So I always prefer unfractionated heparin, in part because you can monitor the PTT. You have high intensity, intermediate intensity. Depending on your health system, you're going to have an ACS, range for a PTT. So you want to be in that ACS range. I like heparin obviously because it's short acting, and then if someone needs additional procedures, if there's any bleeding complications from where you access their radial or femoral artery, you can shut it off. The guidelines do allow for low molecular weight heparin, and enoxaparin being one of the common ones. I think that anecdotally, we often find a higher bleeding risk, even though when studied, the bleeding risks seem to be equivalent. The advantage of low molecular weight heparin is it's easier to administer. It has a more reliable onset. And I think we often see that in our health system for patients that are waiting for their transfer. And you don't want to futz around with a PTT that maybe require a lot of resources in an environment where you don't have those resources. So it's not against the guidelines to use low molecular weight heparin if that's the agent that sort of is most likely to get someone anticoagulated in the short term. Generally, when that patient gets to an institution that's doing their invasive procedure, more often than not, we will switch them to intravenous unfractionated heparin.
And this happens a fair amount. We have patients that come in on anticoagulation for AFib or something else. What do you do in those situations? Like, what do you choose and that kind of thing?
Yeah, so that's great. So if you have someone who's either on warfarin or who's on a direct oral anticoagulant, and they're coming in with an acute coronary syndrome, and you made the decision they're going to have, an invasive, procedure, they're going to have a cardiac catheterization. So generally, you're stopping the warfarin, you're stopping the DOAC, and then if they're subtherapeutic on their INR, that's when you're instituting IV heparin. If they're depending on the DOAC, you'll time the heparin for when you expect that dose effect is going to be, reduced. So you want to still cover them from the antithrombotic standpoint. The timing of the procedure may be influenced by that because bleeding risk certainly will increase, and most cath labs will have a 24 or 48 hour, policy, assuming someone's stable. If someone comes in and they're really unstable, it doesn't matter what their INR is, doesn't matter when they took their apixaban, they'll go to the cath lab. But assuming someone is stable, generally you're going to stop their oral anticoagulant, whether it be warfarin or a direct oral anticoagulant, and then cover them with heparin either after that dose of their oral anticoagulant is worn off, based on the dose, or when their INR is approaching subtherapeutic.
That's helpful. A little bit earlier in the course, like I remember as a med student, I kind of memorized Mona B. So we covered the A, aspirin, but kind of like the oxygen, morphine, beta blocker part of this, like do we still do that? I feel like I don't know if I see it as much as I once did. So I'm just curious, is that like fallen out of favor, or is that just maybe where I work? Or
Yeah, I'd say the one that's probably fallen out of favor is the O, so the oxygen. So now based on a number of different sort of mechanisms. The short version is that if your O2 saturation is greater than 90%, then there's no compelling benefit to being on supplemental oxygen. And there may actually be harm because when you increase oxygen, that can increase oxidative stress, and there could be certainly more reperfusion injuries. So the current recommendation is that if your oxygenation is above 90%, if it's 92, 93, then you don't have to give supplemental oxygen to get it up to 98 or 100%. So that's certainly now more judicious use of oxygen. Morphine is still very effective at alleviating, pain, and we still use it. The only thing that I would say as a caveat is that if someone is requiring morphine, make sure that your plan is not just to sort of treat the pain component of this, but to recognize that that person's probably in a higher risk, bucket now. And the morphine certainly is helpful to alleviate their symptoms, but their syndrome and their acute coronary syndrome, cascade is, putting you more in the higher risk category if you think that their chest discomfort is due to, or their discomfort, is due to active ischemia. So morphine absolutely can be used. Beta blockers are really effective at reducing myocardial workload and oxygen demand. So we often forget that beta blockers are a very effective anti-anginal medication. So I will, depending on someone's heart rate and blood pressure, we'll typically use, beta blockers. And oftentimes it's going to be oral metoprolol tartrate, short acting, and you can dose that up to Q6 or Q8 hours, depending on how easy it is to have the medication administered, but use short acting so you can titrate that. And that can absolutely have a positive impact on reducing someone's ischemic symptoms.
And symptom relief, kind of going back to morphine. So nitrates, that's okay in that before phase, procedurally speaking.
Yes. So nitrates oftentimes are the first agent that you're going to use, and you can start with sublingual nitroglycerin, and then you can redose that. That's typically the initial sort of EMS response, or they're in the emergency department. But let's say now you're taking care of them on, they're admitted. You can't keep pushing sublingual nitroglycerin, so you may use a longer acting version, either nitro paste, which actually is quite effective and sometimes easier to administer because it's absorbed through the skin and it gives you sort of a steady dose of nitroglycerin. Oftentimes we'll use IV nitro because you can titrate it. So someone is really having more chest pain before going to morphine. I would typically escalate the nitrates to IV nitro and see if you can get someone chest pain free. Obviously, there's contraindications to nitroglycerin. Probably the biggest one is just to make sure that they're not using any phosphodiesterase inhibitors. Typically for erectile dysfunction, you want to make sure, that they haven't used that within 48 hours. And it's sort of hard to remember the different versions, what the half-lives are. So I sort of just use 48 hours as a general thing, because that can cause the combination of a phosphodiesterase inhibitor like sildenafil, and nitroglycerin can cause a dangerous drop in blood pressure. So that's sort of my initial screen. Ask someone if they've used those medications, and they're used for a number of different things, including pulmonary hypertension. So it's not just erectile dysfunction. So I ask every patient, regardless of their gender, just because they may be prescribed it for reasons that are not related to erectile dysfunction. The other scenario that you would avoid nitrates is if you're dealing with a really, inferior ST elevation MI where the RV, the right ventricle, is involved. And that sort of go back to sort of, medical school, or when you rotated on the cardiology service, those patients are preload dependent. So when you give nitrates, you're decreasing, venous return to the RV. And when the RV is ischemic, it's not contracting very well. So it's one of those rare situations in cardiology where your JVP is elevated and our response is to give more fluids because you're trying to tank the RV. The other one is tamponade. Same situation. Your JVP is up and your response is not to diurese them or decrease their filling pressures, but actually to try and overcome, the mechanical issue. So those would be the two things that I would think about, with nitro, just as far as an internal checklist to make sure you're not missing.
And then kind of rounding us out in the management piece, as with all things cardiology, GDMT is a thing. So in the ACS coronary space, what does that mean exactly, and when should I be doing it?
Yeah, so great question. So we use GDMT a lot because in cardiology, we like sort of abbreviations and acronyms. So one of my pet peeves, and cardiologists will often describe this as goal-directed, medical therapy. It's actually guideline-directed medical therapy. So that's just a nitpicky thing. It means kind of same things, but GDMT, guideline-directed medical therapy, has more relevance in the heart failure armamentarium where you have, clear, pathways. For acute ischemic syndromes, it's really the medications that we have talked about, where you're thinking about aspirin, you're thinking about, an antithrombotic that's heparin or low molecular weight heparin, high intensity statin, beta blocker, nitrates, for alleviation of chest discomfort. And then you're getting into other medications depending on the nature of their presentation, depending on subgroups. So ACE, ARNI, ARNI, even depending on the population, would be things that you would consider, even in someone who has a non-ST elevation MI. Sometimes there's concern about renal function, and if someone is coming in with chronic kidney disease or acute kidney injury, that may be a scenario where I'll avoid an ACE, ARB, or ARNI. But if they have normal renal function, then an ACE or an ARB can be considered as part of management of their hypertension.
And specifically the ACE or ARNI piece, if they're in that waiting period, do that before? Is that something you tack on like after they come back from the cath lab or whatever it is that they're doing?
Yeah, I think if they're coming in, hypertensive, because one of the things that, all the other things that we've talked about may not lower your blood pressure. And when you're hypertensive, it actually increases your ischemic symptoms. So hypertension increases afterload, increases myocardial workload. So an effective way to reduce angina is to lower the blood pressure. So you'll use whatever agents you need, and ACE inhibitors or angiotensin receptor blockers are very effective. I know that there's always a concern about acute kidney injury when you're going to have, contrast. So if you have someone who has CKD or has an elevated creatinine, then I might use an alternative like hydralazine as a short term, recognizing that the better therapy for them once their contrast the load is completed, once we know what their renal function is, might be an ACE inhibitor or an angiotensin receptor blocker. And ARNI for acute ischemic syndromes is really not part of our frontline therapy. There have been trials that have looked at whether patients with STEMI and LV dysfunction benefit from upfront ARNIs, and it's not clear that there's a compelling benefit. So I usually won't start with that for acute coronary syndromes.
Okay. So Miss Smitha's got all of her medications. She's being medically managed, and now it's like the morning of her catheterization, so like the next day. And she, as like the hospitalist, she has like all of these questions about, what's going to happen, what happens if they find multiple blockages, all of these things. What is some of like the anticipatory guidance? Because I often feel like I get asked that question and I'm like, well, it depends on what they find. And I don't think that really like assuages like the fear of going into the procedure.
Yeah, it's a great question, and the reality is the answer is it does depend on what they'll find, but there's probably a more specific response that will convey that you're sort of presenting different possibilities, and I think that's oftentimes what patients are looking for. I think the first thing is just to make sure patients understand that it's not open heart surgery. Sometimes patients think a cardiac catheterization is actually full anesthesia, intubation, open chest. Most patients, once you've gone through the consenting process, hopefully they understand what the procedures, but you'd be surprised. Sometimes there's a lot of information coming at them. So one, just recognizing that it's usually done with conscious sedation. Patients are awake. They're not intubated unless they're in a sort of high risk, respiratory, status. And you're inserting catheters into arteries. So either the radial artery or the femoral artery, sometimes the brachial artery. And then you're injecting dye, which is the same iodinated contrast that we use for CAT scans. And you're using x-rays to take detailed and accurate pictures of the blood vessels of the heart. So the way I will sort of describe it is that that's the most accurate way of all the testing we had, even beyond coronary CT. It is the most accurate way to determine, one, does someone have a blockage in the blood vessel of the heart? Two, what's the severity of that blockage? And three, it helps you determine what's the best treatment for those blockages. So when I have someone that I'm preparing for, what are the possible outcomes, which is really what that question is getting at. So I usually will present it in, sort of a range of things. So on one end is multiple blood vessels that are involved. They're in locations where it's not safe to fix with balloons or stents, at that time. And it is a type of coronary anatomy or extent of coronary disease where we should consider open heart surgery. So that may be where the patient goes, gets their pictures taken, nothing happens. They come back and it's just a diagnostic test. And then there's going to be a conversation about what's the best way to treat multivessel coronary disease. And there's still a possibility they may end up getting stents, and that gets nuanced into, what their benefit is and what the specific anatomy is. So that's sort of one bucket where they may be faced with a prospect of being evaluated for coronary artery bypass surgery. The other possibility, which everybody sort of hopes for, and we sort of say most likely if we find blockages that are located in areas that we can fix effectively with stents, if it's one blood vessel or even if it's multiple blood vessels, but anatomically something that is appropriate to fix with stents, then it may happen at that same time. So most of the time you're going into the procedure with the understanding that if it's straightforward anatomy, that the interventional cardiologist will fix it with, and I say balloons and stents because angioplasty is the balloon part of it. And now typically we're doing stents in addition to angioplasty. And then, so that's sort of that middle bucket. And the final thing is that we might find blockages that are not critical that can be treated with medicines, or we may find no significant blockages, and then we have to explain your syndrome another way. So I usually present those sort of three big buckets. And then as far as what goes into the decision making, it's really based on what we think is going to be the most effective way to treat that blockage. And sometimes it's clear, open heart surgery, stent. Sometimes it's in the gray area where there's a conversation, and the patient is going to be part of that conversation as far as their preferences.
Okay. So talked a lot about Miss Smitha so far. So ultimately for her coming in with what we're calling her NSTEMI, barring the situation of having any high risk signs, can treat her medically till her catheterization if had any of those high risk signs like the VFib, continued active chest pain despite treatment, or dynamic changes on her ECGs, which may expedite her like catheterization to being sooner. Go ahead with the medical management, and in the meantime, while she's adjusting to this load of information coming at her, just trying to break it down to there will be options that come from it, but kind of these three different buckets might help minimize the load of information coming.
Yeah, I'd say one other test that, if depending on the capabilities, is an echocardiogram. And that's a very useful test to have, because a lot of our decision making, may be influenced by the degree of LV dysfunction or the absence of LV dysfunction. So if you're in a hospital that doesn't have a cath lab but does have echocardiography, that would be an initial test that I would think about for the acute coronary syndrome patients, because that information will help frame their risk. The more LV dysfunction you have, the higher risk you are, but it may also influence the decision making about revascularization.
I think that means we're ready for our last patient. Slightly different flavor. So Miss Linda, she's 62. She has hypertension, diabetes, and dyslipidemia. She presents with new onset fever, cough, and chest pain that's worse with deep inspiration after babysitting her grandson, who just started at daycare and he came home sick. They always do that. In the emergency department, she is found to have a temperature of 102.1, heart rate's 113, her blood pressure's 92/49, respiration's 23, and then oxygen saturation of 85% on room air, and she's placed on 3 liters, and she comes up to 92%. She gets an X-ray in the ER, and it is showing a left lower lobe pneumonia. And due to the initial chest pain, however, you guessed it, she got a high sensitivity troponin that was drawn, and it was elevated. So she got fluids, antibiotics, and she clinically improves for her community-acquired pneumonia in 72 hours. But now we have that pesky troponin that came back. So I think this is the myocardial injury piece you had mentioned way back at the beginning. So can you kind of define that for us as we try to think through this?
Yeah, so I think myocardial injury essentially means some evidence of myocardial necrosis, and that's really based on a troponin. So an abnormal troponin above your upper limit of normal. It doesn't necessarily mean it's ischemically mediated. It could be anything. You can have trauma that can give you a myocardial contusion. You can have inflammation from myocarditis. Oftentimes within this, you have someone who's got stable coronary disease, but then has an event that increases their myocardial demand or decreases their supply, like bleeding, hypoxia, hypotension, and you create a hemodynamic profile where you bring out myocardial injury, even though you haven't had plaque rupture. So myocardial injury, broadly defined as an elevated troponin, using whatever upper limit of normal your system uses. And then I'll try and break down acute versus chronic. So with high sensitivity troponins, acute myocardial injury is where you see that rise and fall. Doesn't necessarily tell you what it's due to, but it gets you in a different category. Versus chronic myocardial injury. And what chronic myocardial injury are patients that just walk around with abnormal troponins. End-stage renal disease patients, some patients with hypertensive heart disease, number of different cardiomyopathies will just have elevated troponins and have chronic myocardial injury. The short version is that you never want your troponin to be abnormal. No matter what the reason for your troponin to be abnormal, it always portends a worse prognosis when you're looking at it from a population standpoint. So as much as I would like to say just ignore that elevated troponin, the reality is that doesn't mean that person is at some degree of risk. And then the question becomes, how do you best adjudicate that risk? And what does that troponin, due to? Is it due to underlying coronary disease, or is it a non-coronary issue that's leading to either an acute or a chronic myocardial injury?
I guess I wonder, is this where we sort of have stopped using like the demand ischemia phrasing? Is that fair?
Yeah, actually, I think this is where it's appropriate. So when we think of non-ST elevation MIs, so within the subset of myocardial injury, there are sort of ischemically mediated events. So you have your acute coronary syndromes, which are type 1 non-ST elevation MIs, and then you have the quote unquote demand, and demand is the type 2, and the type 2 means that you've got coronary disease, and then you have some event that throws off your supply or demand, anemia, bleeding, hypotension, hypoxia. And for this particular case, I'd say that you're pointing more towards the bucket of a type 2 non-ST elevation MI, which is sort of a subset of that broader myocardial injury, bucket. And I think it's important because that subset, when it's been studied, those patients do have higher event rates. And there's some population health studies that suggest type 1 or type 2, your mortality is the same. 2-year mortality is the same. And that's sort of problematic because, you may call the cardiologist and say, oh, it was a demand event, treat the pneumonia, and the patients are fine. And it may be that we're not going to do anything in the hospital, but it's not to say they're fine. And I think that's the disconnect between that consultant who says, I don't think I need to see that patient in the hospital because I'm not going to cath them while they have their pneumonia. But that's different from saying, I don't need to see them eventually. And part of this is actually requires ongoing study. And there are a couple of prospective trials that are trying to define what's the best treatment for the type 2 NSTEMIs, because we know there's risk in that population. And sort of one approach, if you have that patient and you're not calling because you think they need to be rushed to the cath lab, but you don't believe that this is a plaque rupture event or an acute coronary syndrome, but you want some assistance in trying to understand, well, what is their underlying risk? And are there things I should do in the hospital to help lower that risk, or plan a transition of care that's going to help identify, that risk? And there's a number of different sort of pathways that you can go depending on the individual patient. I think an echocardiogram is always helpful to just give you some sense of their substrate, even if they're coming in with a non-cardiac diagnosis, like this patient with pneumonia, because you can see if they have LV dysfunction, do they have wall motion abnormalities. Almost every patient that we take care of has had a chest CT of some sort at some point, either during that hospitalization or before. So I'll always look at that chest CT and just see if I find incidental coronary calcifications, right? It's not a cardiac CT, but the CT scanner technology is often good enough where you might see incidental coronary calcifications, or the radiologist, may comment on that, or your cardiologist will take a look at it and say, this person has a lot of coronary calcium. So that may influence, do I think about a strategy of statin therapy? Like once they're done with their pneumonia, will you check their lipids? Will you think about, an approach that may even, in some cases, you'll think about an aspirin, even though it's not necessarily supported by prospective studies, but there may be clinical scenarios. What happened to their EKG? How bad is their substrate? What's their bleeding risk? Where you might actually address their coronary risk, during this hospitalization. And then ultimately, those patients may benefit from an outpatient assessment. And that may include additional testing, sometimes even stress testing, depending on the nature.
Okay. So on the inpatient setting, echo is probably as far as you would go while they're here in the hospital. So from what I'm hearing, if they have an elevated troponin, probably can't ignore it. Like we probably have to address it. And the echo would probably be where you would stop in the hospital.
Yeah, I think the echo would be where I would start and then use that to help guide things. So whenever I'm on the consult service and the fellow says it's a demand event, I sort of translate that the fellow doesn't think this person should go to the cath lab. They're busy. They have a lot of patients to consent. They've just decided this patient, for whatever reason, with their elevated troponin, doesn't warrant a cath during this admission. And the challenging part is that even in patients who come in with sort of a sepsis picture or pneumonia picture, they're actually, if you do intravascular imaging, intracoronary vascular imaging, they may actually have ACS-like plaque rupture. So it's become a little bit more muddled, is that it's not so finite that you can say that person has completely rock-stable coronary disease and they had this pneumonia. So I think that's where if they have, symptoms. So let's say they have ischemic symptoms after you've addressed their sort of initial diagnosis, whether it's, a pneumonia or GI bleed, sepsis, whatever. If they have EKG changes that are dynamic, that certainly is someone that you may think about. And there are patients that come in with what we would describe as a type 2 demand event, but their substrate is so concerning. The echo is very abnormal. They have recurrent ischemic symptoms. Their EKG was very concerning or dynamic, where we may still make the decision to actually define their coronary anatomy even before they get discharged. So I think that's where I wouldn't try and force yourself into thinking that it's always going to be, if they've got a pneumonia, you can ignore the troponin on the inpatient side, because some of those patients may actually have plaque rupture, and many of them actually have important coronary disease. And some of them may benefit from defining that, at the tail end of their hospitalization once their acute non-cardiac illness is addressed.
I just want to highlight this because I think that at least makes mechanistic sense to me, because their event, we would always say is kind of their pseudo stress of for their coronaries. And so
They've kind of failed its stress test in a lot of ways.
yeah, but I understand kind of the logistics of it, during that time, that may not be the most appropriate setting to test them and everything. So I think that's a good point to maybe segue into talking a little bit of transitions of care, because for her, you want to make sure you have, I guess, pretty close follow-up maybe with a primary care, or would you send her to a cardiologist?
Yeah, it's a good question. And I think part of it depends on the magnitude of some of the objective findings. So I think the EKG and the troponin, the absolute magnitude of those abnormalities, if they were very abnormal, if you had LV dysfunction or wall motion abnormalities on your echocardiogram, then I'd probably, err more towards the side of them seeing a cardiologist, again, assuming it's within their overall goals of care. I think that from a PCP standpoint, part of it is that in that discharge summary, you are acknowledging that they had myocardial injury. You're concerned that they may have underlying, coronary disease. On the inpatient side, you didn't proceed with any diagnostic testing because you wanted them to recover from their non-cardiac illness. But it's a reminder that that conversation should continue. And at the very least, they should be probed for symptoms that might now become more apparent, or the PCP can decide, okay, I'm concerned enough that I should refer this person to a cardiologist. So I think when you have that myocardial injury, or you're defining as a type 2 NSTEMI, the key point is that there's risk in that population. The bigger question is, how do we manage that risk? And we don't have prospective, clinical trials to say that all these patients should get X, Y, or Z as far as medical therapy, or all these patients should, undergo stress testing, or all should undergo cardiac cath. Within that population, there are a number that will benefit from some combination or all of the above.
Then going back to also with your patients with NSTEMI included.
Jared and Miss Smita.
Thank you. You're both of them would go to cardiology as well, or primary care?
Yeah, I think if you've had someone with an acute coronary syndrome, they should follow up with a cardiologist.
Okay.
I think, and again, they can be co-managed. It doesn't mean that all of the cardiology care or the care of patients with coronary disease is going to happen with a cardiologist. Part of it just depends on availability and comfort level, and I think that's where we probably don't do a good job as physicians of really outlining, here are the next steps. Here's why we didn't do this, but here's what you should do. Once their creatinine is normal, you should get them on an ACE inhibitor, or here's the duration of dual antiplatelet therapy if they had a stent. So I think that transition is really important, and duration of those therapies also is going to change depending on the patient. So I think oftentimes, if it's available, having cardiology follow up to at least establish what the short-term plan is going to be. But the reality is that you're really managing these patients together between the primary care provider and the cardiologist.
And who on discharge gets referred to cardiac rehab?
Yeah, so my bias as a big supporter of cardiac rehab is that everybody should be referred to cardiac rehab. So if you come in with an acute coronary syndrome, you should be referred to cardiac rehab. Insurance is probably the biggest barrier, and then sometimes it's distance, depending on where the cardiac rehab programs are. But if you look at the mortality benefit for cardiac rehab, there are very few things that we do that have such a profound effect on morbidity and mortality. And if I were to get on my soapbox, I would say, cardiac rehab should be the drug that we get approval for everybody. Because structured exercise, it's not just the exercise, but good cardiac rehab programs, build confidence with returning to exercise. There's a lifestyle modification component to it, including stress management, dietary intervention. So comprehensive cardiac rehab programs, I would say anybody who presents with an acute coronary syndrome, you should refer to cardiac rehab. It is underutilized, in most health systems, and it's multifactorial. Some of that is a lack of awareness. Some of it's a lack of capacity. But whenever possible, I would say the default should be, and encourage patients. Don't describe it as being something that's optional. You can tell them you will live longer. You will live longer if you go to cardiac rehab. And that's actually a fact.
And is that under the assumption that they've had their treatment? Meaning, like, if you had someone who got cath, they were leaving, but they're like deciding what they wanted to do, still like refer to cardiac rehab, like in the interim?
Yeah, that's a great question. So it depends on where they are in their revascularization journey. So some patients are going to be revascularized during that hospitalization. So they'll get a CABG, they'll get stents, and then you've sort of treated their obstructive coronary disease, or at least you've treated as much of it as you plan on for that period of time. Those patients you can refer to cardiac rehab. In most programs, within 2 to 4 weeks, it's reasonable to begin that process. Obviously, it's dependent on the patient. If someone's had a sternotomy, sometimes it takes a little bit longer before they're really ready to exercise. I'd say it's probably more in the 4 to 6 week range for those, post-bypass patients. If it's someone who is going to need revascularization, but there was some compelling reason to delay it, or you need more time, or if you're going to pursue a period of medical therapy, I'd say that final category, cardiac rehab, is still absolutely indicated. In some ways, it gives you some sense of how symptomatic they are as they start to return into more exercise. It also gives you a gauge of how effective is your medical therapy, right? So the cardiac rehab team is going to be tracking their symptoms and feeding that back to you as their primary care provider or as a cardiologist. And that way you'll get a sense of whether or not your strategy of medical therapy is effective. Patients who've had a cardiac arrest or other, syndromes that, may require more time, obviously that you may sort of delay the window. One of the things is that you don't have to figure all of that out on your own. That's where the cardiac rehab folks are really exquisitely talented in determining what's the level of activity and what pace should that patient enroll in the program.
And when they're leaving the hospital, like in that interim before they get to like a cardiac rehab opportunity, kind of, do you counsel on limiting activity then, or just do what they feel like they can?
Yeah, it's a great question. I think the first thing is you have to comment on activity, because sometimes patients will think they can do everything that they want and they'll start shoveling snow here in Maine without any understanding that they were never really fit enough to shovel snow before their heart attack, and probably not fitter afterwards. Or they'll think that they can't do anything. And they will really actively decondition and worsen their metabolic profile because they think it's too dangerous. So the reality is it's somewhere in between. So I would say, depending on the specific anatomic features, depending on, if there's any issues related to their catheterization site where you may delay heavy lifting for some period of time, there may be specific, features. But in general, you want patients to start to resume some activity. And I tell them to do it gradually. So you're not joining a gym and starting to lift and sort of, run on the treadmill, but start walking and use the walking to gauge how you're feeling. And if you're having symptoms with, increasing levels of exertion, that's your body telling you to slow down. And then you need to check in with your primary care provider or, the rehab nurse that's working with you, or your cardiologist, because that may be a clue that either the medical approach isn't working, or you need to slow it down, a little bit. So I think you want, patients to sort of start to get in tune with their bodies. And that's probably the other thing that is different for someone who's never had coronary disease. All of a sudden, they're aware of their chest as a region of their body that they were completely oblivious to. And we all get little blips of chest pain. And you probably remember as a medical student, you had your cardiovascular course, and you're like, all right, am I having an MI? I felt a little, twinge. After an MI, most patients will feel some fleeting chest pains. And that's not the same as their stent occluding or them having symptoms of ischemia. But that takes some time and comfort to sort of, reassure them and yourself that their symptoms are not concerning. So I think mentioning to patients that you can do activity, customizing it to that individual patient, using your cardiologist and your cardiac rehab team to help add some structure to that. So that way you are not having them overdo it where they might be putting themselves at increased risk of future ischemic events.
Anything else?
No.
All right. We have covered a lot of ground, Sanjeev, as I'm sure you're aware, given the hour. But do you have any major take-home points for the listeners?
Yeah, so I think these cases were fantastic, and they sort of cover a lot of contemporary, topics in chest pain and acute coronary syndrome. So kudos for really, putting together, I think, some great cases that highlight some of the areas of uncertainty and evolution in our guidelines. I think one thing in cardiology is that it's always changing. And even as I think back to my residency and fellowship and junior attending life, there's been sort of incremental changes in the guidelines. So, reviewing the guidelines, not the 120 pages that are published, but most of our guidelines now recognize that our attention spans are not, 7 hours, but 15 minutes we can probably get by. And for something that's as important as sort of managing suspected coronary disease, they'll often have sort of take-home points. There'll be 10 quick points. So I would encourage people to look at the 2021 ACC AHA chest pain guidelines and just read the highlights. The highlights don't take very long, and it can sort of help maybe reframe how you think about chest pain. The nuances of revascularization are going to be much more complex, but understanding that those nuances exist can help you counsel patients as you're preparing them for what's going to happen before the cath lab, or when they come back and you're trying to sort of prepare them for, okay, there's going to be conversations about what the best approach is. The medications are always changing, and the indications for the medications are always changing. So I think that's important to sort of recognize that we moved away from obligatory upfront P2Y12 inhibitors for patients that are coming with acute coronary syndromes. That's a pretty big change from the past. I think you commented on the inclusion and the escalating rule of coronary CT, not as a replacement, but as part of the spectrum of testing that you can now think about for those patients that are intermediate risk. History can be very helpful, but all of us recognize that sometimes it's just not, and that's okay. Sometimes a history is not going to really help you because of the patient's just a vague historian, and we've all taken care of patients where the history really doesn't help you, and then you have to rely on some of the other objective clinical decision, protocols that will hopefully help you refine and standardize your approach.
Great. And do you have anything you would like to plug?
Nothing. This was great. I appreciate the invitation to participate. I can tell my kids I participated in a podcast, so maybe they won't roll their eyes as much at me, but this was awesome for me, so I appreciate it.
I always tell the guests that are not millennials or younger that this is going to do wonders for your street cred with students and residents, I promise.
Yeah, and I bought these fancy gamer headphones, so I can, I'll see if that gets me some street cred at home.
Awesome. Thank you so much. We really appreciate it. It was a great time.
No, great job. It was a lot of fun.
Thanks. This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Still hungry for more?
Yep.
Join our Patreon and get all episodes ad-free plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox, including our Curbsiders Digest, recapping the latest practice-changing articles, guidelines, and news in internal medicine.
Here at the Curbsiders, we're committed to high-value, practice-changing knowledge, and to do that, we need your feedback. So please email us at askcurbsiders@gmail.com. It also helps when you subscribe, rate, and review the show on YouTube, Spotify, or Apple Podcasts. And a reminder that this and most episodes are available for CME credit for all healthcare professionals through VCU Health at curbsiders.vcuhealth.org. Special thanks to our Curbsiders team. Technical production is done by Podpaste. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Chris the Chew Man Chew moderates our Discord. Stuart Brigham composed the theme music. And with all that, till next time, I've been Moni Amin.
And as always, I've been Meredith Trubit. Thank you and good night.